When we ventilate our patients, we need to understand our physiologic goals. So what should they be? Let's find out. Hello there, and welcome to my YouTube channel. If this is your first time here and you want more of this content, don't forget to hit the subscribe button below, and if you hit the bell, you'll get notified whenever I release more content. The primary goals of mechanical ventilation should be to cause no additional injury, maintain gas exchange and acid-base balance at a level appropriate for the patient, and ensure patient-ventilator synchrony. Returning blood gas values to a normal range, irrespective of the tidal volume delivered, pressure applied, or amount of oxygen given, may not be the most prudent idea. Doing so can cause lung injury, activate inflammatory mediators, and potentially cause or extend multi-system organ failure. Those patients particularly at risk are those with lungs which already have abnormal mechanics, such as acute respiratory distress syndrome or chronic obstructive pulmonary disease. In order to optimize the physiologic goals of mechanical ventilation, we need to address a few issues. Tidal volume, alveolar distending pressure, positive end expiratory pressure, permissive hypercapnia, oxygen toxicity, realistic gas exchange targets, and patient ventilator synchrony. Tidal volume. We should be aiming for lower tidal volumes than we have in the past. The ARDNET study suggested that we should be aiming for 6 to 8 mils per kilo for our patients to prevent some of the stretching and shear forces that may result from higher tidal volumes. Alveolar distending pressure. To be aware of some of the pressures we are exerting on the patient's lungs, one of the best measures we can use is end inspiratory plateau pressure, which reflects mean peak alveolar pressure. The best way to measure this is to have a 0.5 to 2 second respiratory breath hold. We should try to limit this pressure to a maximum of 30 centimeters of water to prevent further damage to the lungs. Positive end expiratory pressure. There are recommended levels of positive end expiratory pressure to be applied to maximize the patient's oxygenation and to further reduce the injurious effects of mechanical ventilation. One needs to be aware, however, that if the PEEP is set at 10 centimeters of water, for example, and we are limiting the plateau pressure to 30 centimeters, then there is only a 20 centimeter driving pressure available. This may result in lower tidal volumes than recommended. Perhaps under the circumstances, minute volume needs to be adjusted by increasing the respiratory rate. When using PEEP, one always needs to be aware of those patients with flow limitations, for example COPD. The standard lower level of 5 centimeters of water of PEEP will help maintain functional residual capacity and prevent atelectasis for most patients. This level of PEEP will usually have no adverse effects. Permissive hypercapnia. It may be that one needs to allow a rise in the carbon dioxide levels or permissive hypercapnia in order to provide the necessary oxygen, whilst not stretching the lungs to a potentially dangerous level. There are clearly some physiological effects of a higher carbon dioxide, such as a shift of the oxyhemoglobin dissociation curve to the right, stimulation and depression of the cardiovascular system, and increased intracranial pressure, to name but a few. Because of the effects of the shift in the oxyhemoglobin dissociation curve and the fact that an increasing alveolar PCO2 results in a decrease in alveolar PO2, where permissive hypercapnia is allowed, every effort should be maintained to maximize oxygenation. One of the biggest problems with permissive hypercapnia is the acidosis that can often result. Those patients without other conditions can usually tolerate a pH as low as 7.2. This fall in pH needs to be evaluated on an individual patient basis. If the rise in the PaCO2 is a gradual one, then renal compensation can occur. There may be an argument for using buffers to help compensate. However, this is very debatable. Oxygen toxicity. This can also be of concern in the very sick, lung-injured patient. In animal experiments, oxygen of 100% resulted in non-cardiogenic pulmonary edema within 24 to 48 hours. Bearing this in mind then, it should be the lowest concentration of oxygen that achieves the desired PaO2 which should be used. It may be necessary then to accept a lower PaO2 rather than suffer from the effects of high concentrations of oxygen or higher stretching pressures. Realistic gas exchange targets. What should they be, bearing in mind some of these limitations? You can see some of the recommended targets here, bearing in mind the severity of the pulmonary disease. A normal carbon dioxide level should be the aim, unless the risks of a high plateau pressure or tidal volumes outweigh the benefits of this. Carbon dioxide can be allowed to increase to as high as 10 kilopascals, providing increased intracranial pressure is not of concern, and that the metabolic acidosis does not become too deranged. When we do limit plateau pressures and tidal volumes, and carbon dioxide is allowed to increase, potential for acidosis exists. If this is gradual, and as long as the kidneys and the heart are functioning okay, then a pH of 7.2 to 7.3 is usually well tolerated. Patient ventilator synchrony. Another objective is to maintain patient ventilator synchrony. Asynchrony is a concern because it increases oxygen consumption, carbon dioxide production, hemodynamic instability, and sedation requirements, and may contribute to a ventilator-induced lung injury. So before increasing sedation, it's probably important to assess the ventilator settings to see if they can be changed to reduce this amount of asynchrony. So you can see that we have a number of options available to us. Aiming for normal is not always the best option, and we have to be pragmatic about some of the choices we make. This video is one of a series on mechanical ventilation. If you want more, go and check these out, and remember to subscribe. Speak again soon.